there are only 2 PAs that we know of, me and my colleague, that are doing this kind of medicine. It's hospital-based home medicine.
Hi, everyone. Hi, welcome to eShadowing. Hi, guys. Hello, everyone. We have Ryanne here today, and Ryanne is a hospital medicine PA. Hi, Ryanne. Thank you so much for coming on.
Hi, thanks for having me.
Of course. Thank you so much. So, guys, Ryanne's been a PA for 14 years, and most recently, she's now in hospital medicine. So this session is going to be all about like inpatient and being a hospitalist PA. So, of course, we're going to answer any questions you may have. But first, I'm going to ask Ryanne a little bit about how she became a PA and what she does as a hospitalist. So, Ryanne, can you tell us a little bit about your route to becoming a PA and how you got to being a hospitalist and the different specialties you've done?
Sure. So starting out was a long time ago, so we're going to go back in time. But as an undergrad, I was a biology major, and I didn't quite know what I wanted to do with it. I knew kind of what I didn't want to do, and didn't have much of a plan for where I was going to go with it long term. So I started talking with my other friends who were also biology majors. But at the time, I had always had work study jobs at Children's Hospital in Pittsburgh. And so through that, I was in the medicine world. I kind of thought I wanted to do medicine. Eventually shadowed a PA who was a pediatric neurosurgery PA and was kind of blown away with what she could do. She was interpreting MRIs and doing spinal taps on patients, and was kind of enthralled with the amount of care she was able to provide. So that was kind of it for me. I went straight from undergrad to grad school. It was a long time ago, so back then that wasn't so unusual. Not so common now with more gap years in there, but it wasn't out of the ordinary then. So straight out of school, I knew I wanted to do oncology. I worked at the University of Pittsburgh Cancer Institute for a year in melanoma, sarcoma, and GI cancers. I then went on to MD Anderson in Houston, Texas, which is the biggest cancer hospital, top-ranked cancer hospital in the country. I had a clinical rotation there, which is how I got there, and I loved it. And I was there for 11 years in GI oncology. And then a couple of years ago, I moved to Boston, and the Northeast is very heavy in hospital-based PAs and inpatient PAs. And so I was outpatient before and did a mix of some outpatient, some inpatient, in my old role, maybe 20% inpatient, but found that the roles I was really drawn to here in the Northeast were primarily hospital-based, inpatient-based. And the kind of work I got to do here was really what drove me. I would have never planned on leaving oncology on purpose, but what I got to do with the project I'm working on now with hospital medicine at Massachusetts General in Boston is really what led me to make the switch from oncology to hospital medicine. I should probably say too that I work in a subset of hospital medicine. So we kind of have this little off to the side project that I'm a part of. It's called Home. And there's not a lot of unused real estate. We are a coastal city. So if you build, you have to build up, and you can only build so high. So our hospital is constantly overrun, is over capacity. And so we take patients who are stable enough, but still need hospital level care, still on oxygen or IV medications or something like that. We take them home, and we go treat them at home for the duration of however long they would have been in the hospital, and bring out the antibiotics to them, bring out the oxygen to them, bring out whatever they need, and treat them at home. So it's a little unusual. There are only 6 Medicare approved programs in the country. There are only 2 PAs that we know of, me and my colleague, that are doing this kind of medicine. It's hospital-based home medicine. But I think we're going to see a lot more of that in coming years.
Really nice. I'm sorry, I think my audio was off, but how long have you been in hospital medicine?
So just about 2 years. I started early 2019. Was that what was 2 years ago? It's been a long year. I started early 2019 in hospital medicine.
Okay, and how easy or hard was it to get a job in oncology as a new grad?
That was shockingly easy for me. I think subspecialties are often really willing to train newbies because the medicine is so specific that it often doesn't matter if you have much of a background. Like, there's not a huge advantage to coming from general practice to going into subspecialty medicine. So I think a lot of subspecialties are pretty open to training PAs. I had 2 oncology rotations as a PA student, and one of them was at MD Anderson, which is kind of the big cancer hospital. So I think if anyone working in oncology kind of sees, if they see that you're applying for a cardiology job and you had a clinical rotation at the Cleveland Clinic, that kind of matters to the people looking at your resume. So that can make a difference, knowing that you showed some interest in it as a student.
Okay, awesome. Okay, so can you tell us about a day in the life of a hospital medicine PA?
Yeah, every day is sort of different. And as I'm sure all of you have been experiencing who are working in medicine right now, every week and month is a little bit different this year. But essentially, our program is the clinicians are APP. So the clinicians that see patients regularly and see them every day, it's 2 PAs and 1 nurse practitioner on our team right now. We're about to have a big expansion, but so in the morning, we have a morning huddle where we get together with our nurses for the day, our attending physician for the day, who usually is remote. Unless we have a new admission, they'll go see the patient once, but otherwise our attending is remote and available if we need them. And the APPs come together. We kind of have 2 different teams. We cover different areas of town because we have to get our bodies to all of our patients to see them. And so in the morning, we have a huddle. We talk through all the patients, talk about the care that they're going to need for the day. Because we are taking everything into the home, including the tubes that we need for blood draws, including the IV medications, we have to know what the plan is going in. We can't come up with changes in plan on the spot that we're not ready for. So a lot of that morning discussion is, are we going to change their medication? We need to make sure we have it with us. Do we want some sort of specialty test? On occasion, you've learned a lot about what happens in the inner workings of the hospital that you never know about when you're doing what I do. And so sometimes the tube has to be on ice, which you would never know. The phlebotomist would do that for you. And so sometimes there's a relay race to get someone's blood draw on ice and drive it into the hospital and toss it to a colleague at the front curb. So we do all that planning in the morning. We go out and do morning rounds on our patients. So we can have typically up to 4 or 5 patients, which depending on the geography can take a long time to see them. And then we basically are triaging through the day because we are not doing notes and we are not, often we are not able to put in orders when we're on the road. And so the morning's kind of crazy because fielding pages and new referrals and requests for admissions and also seeing patients. And then the afternoon kind of settles down and we do notes and orders and kind of plan on what's happening the next day. Right now, we're also manning this project, which was brand new for COVID, where patients who are COVID positive and known COVID positive in different clinics that we have around town who are borderline. They're stable, but we're worried something might happen in the next couple of days. We're also heading up a program where a paramedic will go into their home and check on them in a day or 2 later. And one of our APPs will join by a virtual visit and just see if there are any high-risk signs or symptoms that patients exhibiting, if it's safe for them to be home, and follow up with their PCP. And then we touch base with their PCP and tell them what happened, or if they need to come into the hospital, bring an ambulance in, whatever it may be. Right now, we haven't gone into the home for patients because those morning patients that we see are often elderly. They're often isolated, which they should be. There are reasons they don't want to come into the hospital, which is why we're trying to get them home early or keep them home. And so we can't basically cross-contaminate our team. So we're not the ones going out and seeing the COVID positive patients, so that we're hopefully isolating ourselves to take care of our more vulnerable patients at home.
How are your shifts and as a hospitalist? I know for a lot of hospitals, they do like 7 days on, 7 days off. Is it like that?
Oh gosh, no, I would never be able to. Maybe once upon a time. That's intense. And I know a lot of people who have done that. I know a lot of new grads who do that. That's a lot. You're kind of holding your breath until that's over. And then you have a few days where you finally feel caught up, but no. So our schedule is very much in flux because there's only three of us. And so we work a lot together to kind of facilitate our time and make sure that we're mindful of the days other folks need off, because we don't have a very deep bench. We don't have a bunch of people who can fill in if we're not there. But the general design of our program is that we work 4 10-hour shifts. I actually earlier this year, probably around February of this year, scaled back where I work about 80%. Because I also coach aspiring PAs and PA students, PA grads, run a community, and it's got to be a lot. I spend a lot of time doing that, and doing that on top of full-time work if there was just no other space in the day. And so my schedule is a little bit different than the other two APPs, and that most weeks I work one less shift than they do. We also right now do overnight call. Half of the time that we're on, that's intense. That is a lot of what we do is just a temporary thing to see how it works. And then we float it to some new design because our program is growing and developing and we're trying things out. And there have been periods that are really intense, especially when we took on this COVID project too. They're really intense, but we know they're temporary. We're just trying to see what the kinks are, and we'll pass off things in the future. So eventually there will be someone who takes night call because it's too active to see patients for 10 or 12 hours a day and then be the one on call all night for 4 nights in a row.
Wow, I was actually gonna, just ask you that about being on call. So are you ever on call, or do you rotate every other weekends also?
So we have some per diem folks that fill in for some of the weekends too. So I probably work one weekend every 5 or 6 weeks.
Okay, awesome. So I know you touched a little bit about the COVID project your group has taken on. How else has your hospital changed with COVID, or even early on, how was it impacted, and what else are you guys doing different, especially, as a hospitalist?
Yeah. So the nice thing about one of the many nice things, and I've always worked at academic centers, like places that just have a big infrastructure, places that have a lot of PAs, a lot of planning teams, disaster planning teams. And so at Mass General, there are teams that basically have been prepared for something like this for years. And so you basically kind of flip the switches and you go into emergency mode. And so we did what a lot of hospitals do is we kind of cut out all visitation for a while. Coming into the hospital very early on, most folks were getting, and now all folks get, everyone that hits the ED, everyone gets screened for COVID. Now things have changed that even folks, once they've been on the floor for a certain amount of time, they've been admitted for a certain amount of time, even if they tested negative upon admission, once they cross some threshold of so many days in the hospital, they get retested because it's possible that people get infected in the hospital. We have dedicated COVID floors where we're separating out, obviously, the COVID patients from others. And then our hospital system has what's called respiratory infection clinics. And if a patient calls their PCP within our network and they have a suspicion for COVID, they're either going to the emergency room or they're going to our dedicated respiratory clinic so that those patients are not infiltrating into their primary care offices. And from the ED or from those respiratory clinics are where those referrals for the paramedic visits are coming from, to make sure that as best as we can, we're separating out. And so there was talk of, people who hadn't been in the ICU going to the ICU initially, like scary things, like things I shouldn't be doing, things you don't want me to be doing with my background in GI oncology. But certainly it's been less intense. We have a lot of resources, a lot of nurses with ICU experience who could be pulled in. And we got close to capacity, but when COVID was at its worst here in Boston, we kind of got hit early, and then everyone's been scared and kind of behaving themselves for the most part. The other things people go to the hospital for went way down. And so even though we had a lot of COVID patients back then, we weren't seeing people with kind of more minor complaints or elective surgeries and things like that. All that kind of went away. And so by the time that kind of came back, our COVID had decreased, and we kind of had a handle and had more experience treating patients too. So we knew what was effective, who was likely to going to deteriorate. There was a big learning curve for a lot of clinicians. And I think everyone was kind of scared at first, but learned, got better. And I think there's definitely a comfort level as a clinician, knowing who to be suspicious for, that they're likely to get worse, or they're in that window that they can tip. And we didn't know that in March and April. It took a little while to see that play out.
Definitely agree. Yeah, I heard the ER, especially when things started. I mean, at first it was, everything was all over the place. We didn't know what was going on, but we've definitely implemented more of a system and, testing, patients that come in. So yeah, that's great that you guys are, have something in place, as, all hospitals now do. Yeah. But, and another question I have for you as a hospitalist PA is, do you also see patients outpatient? Like with your group, do you guys have a clinic also?
No, we're strictly hospital based. There is, like, within Mass General, it's very integrated between specialists and primary care and things like that. So the vast majority of patients who come into the hospital also have their primary care physician within the same hospital network. And so it's really easy for us on discharge to just message the PCP within our system. A lot of them we know, and just ask for follow-up for a patient. So no, we're strictly hospital-based. A lot of our doctors are attendings, because their role is kind of a lot less than ours, do different things. So some of our attendings are primary care physicians. Some of them are critical care physicians. Some are hospitalist physicians. We have geriatricians and nephrologists, and a lot of faculty members and physicians who work with us who have all sorts of different backgrounds and who do have their own practice. But our core team, our nurses and our APPs, only see patients as part of our program.
Awesome. And somebody actually had a question about like your role versus NP or nurse practitioner's role. Of course, in the ER, it's basically do the same thing. Would that be the same as far as hospital medicine?
Yeah. Functionally, in practice, a lot of PAs and NPs do the same thing. As long as if they're employed by the same department, they do the same thing. It's no different. It's just our backgrounds can be different. So kind of where we worked before can be different. Where we might work in the future can be different based on some limitations and some training. But if you have a role, you're both APPs, whether it's outpatient, whatever the same practice is, you do the same thing. There's no difference in practice. It's just about past and future that might be different.
Exactly. I definitely agree. Okay. So, of course, really quick before we move on to case studies, guys, as I said, Ryanne is also a PA coach. She has a really great platform, Be a Physician Assistant, where she helps and coaches pre-PA students and helps them get into PA school. So, Ryanne, can you go over and touch a bit on your platform and how you help students?
Yeah, so this was born out of back when I worked at the University of Pittsburgh. I worked with my attending there who went on to work at the University of North Carolina. I went to Texas. At UNC, he actually worked with a lot of nurse practitioners. He didn't work with PAs anymore, but he worked with a lot of research assistants who wanted to go to PA school. So he kept, every 3 or 4 months, he kept sending me research assistants to talk to. And eventually I said, if you're going to send me every research assistant that works at University of North Carolina, I'm just going to create a blog and write all my thoughts down there, and that's where they can start. And so that's kind of how things started. And a lot of the questions I had back when I was a PA student, people still had. It had been years. I had already been a PA for almost 10 years when I started it. And people still were asking the same questions I asked. I'm like, oh, hasn't anyone told anyone yet? So I think that the information's out there. There's so much more out there than when I went to school, but there's also a lot more prep that a lot of people are doing. And there's a lot more awareness of the profession. There are a lot more applicants, but there are also a lot more schools. So I don't know if the odds of getting in have gone down at all. But really, I think what I offer people the most is just an idea that they're on the right path, and to feel like they're on the right path, because a lot of times it just feels like you're working without any parameters. And a lot of times you're working off of hearsay, like, I heard that it's good to do this for PA school. And I think you can be a little more precise in your approach, and through that gain confidence in what you do. So I work, I've moved a lot because it's gotten big to the point that I had to go part-time. And I've moved more towards group things because I feel like it can serve more people at once. So I have a community. I do kind of a group coaching session that leads up to the application in the spring. And I do interview prep too. So I have kind of one-on-one stuff that I do for folks with essays and applications and interviews. And I also have programs that you can go through on your own to kind of get guidance if my time's not available to you, or if you want to kind of start in advance before you're ready to get down to the nitty-gritty details of your own plan. It gives you a runway to get those ideas down for yourself. So it's nice. I always love hearing when people get in, and love hearing just that, seeing that confidence whenever they get closer and they know that their plan's in the right track. So I didn't want to give that up. I kind of like doing a lot of different things. I've burnt out before, so I know that that's important to avoid. But it's been great, and it's grown over the years, and gives me a chance to write and connect with future PAs and all sorts of things that I didn't foresee being part of my career in the long term, but I've really enjoyed.
That's really, really great. Yeah, I was on your website earlier, and I was just like, wow, this is awesome. Your Instagram page is great, and I think it's very much needed because you're right. Like, a lot of the problems you had back then, like, people are having now, and it's crazy. Yeah. And, even when I applied to PA school, like, I applied like 7 years ago, and students are still coming into me, with the same questions that I had. So it's a great tool for students. So everybody, we have her link to her website, beaphysicianassistant.com, and her Instagram is at beaphysicianassistant. There's so many resources out there, of course, but you don't know what to believe, what's real, what's not. So she's a great reference. Yeah. Thank you so much for your platform, Ryan. Thank you so much for your platform.
Sure. Okay. Is there anything else? Do you go to case review?
Yeah, so we're going to actually move on to case studies. So it's going to be a little different today. Ryan's going to actually present a case study, and then we'll have a student come on, and she'll ask questions about the case, and we'll give you a chance to answer questions. So Ryan, I'll let you present your case study.
Okay.
For case studies.
And some brave soul really does come on, and
if you want to come on, if you want to come on for the case study, make sure you raise your hand. So once she's done, we'll be ready to ask you questions. So I
will be gentle, I promise too. Okay. So let me run through this first case. I have two if we have time, but I think you'll get plenty out of this first case if you've got questions about it. So awesome. Our first case is kind of a classic case that comes our way. So this is a gentleman coming into the emergency room before he makes his way to us. So it's an 82-year-old gentleman with a past medical history. I'm sorry, this is complicated. I did this slide for both pre-PA and PA students. But what this means is he has heart failure. So HFpEF is heart failure, coronary artery disease, hypertension, atrial fibrillation on anticoagulation, so on blood thinners, mild COPD. He's not on oxygen at home. He's got chronic low back pain, takes opioids. He presented to the emergency room with a 2-week history of progressive shortness of breath, weight gain, and was found to have low oxygen level, 91%. Right now, your oxygen level is probably about 98, 99%, assuming you're not working out while you're watching this case presentation. So this is what we see on exam. So he's got chronic lower extremity edema. So he has leg swelling that's always there. That hasn't changed. On his lung exam, he has crackles in the bases. So when we listen to kind of the lungs near the bottom of the rib cage, he's got sounds there that he shouldn't have. He has a BNP. So this is a protein level that we measure in the blood that is linked to heart issues. And so it's not only seen as elevated in certain conditions, but it kind of starts pointing us towards a certain direction. So that protein level is elevated. On his chest X-ray, he's got interstitial pulmonary edema. So what that means is the lung tissues are swollen, which means that there's probably fluid that's causing that. And he's got bilateral pleural effusions. And so effusions are collection of fluid that we see at the bottom of the lungs. Let me see if this plays. See if the audio plays. Nope. Okay. So what you're not hearing, and the sound I can't make, were crackles in the bases. So when you hear crackles in the bases, you hear it at the end of someone's breath, because the fluid is at the periphery of the lungs. And so you're not going to hear it until the air gets there. And you kind of hear at the end of the inhalation, the crackles, and that tells us where the fluid is. If we hear noises that are only located in one spot of the lung, it might mean that there's something else. But this is on both sides, suggests that there's not like a pneumonia going on that would be on one side versus the other typically. So our diagnosis, based on all of these things lining up, is that he's got an exacerbation, a worsening of his chronic heart failure. And so no one of these things tells us that. Not the crackles in the bases, not this protein level, not what we're seeing on chest X-ray. Add them all up and it points to heart failure. So that's the case with a lot of conditions. This guy also has COPD. So if he's coming in with shortness of breath, might be his COPD, but we wouldn't expect to hear these sounds in the lungs with COPD or see this protein level. He doesn't have signs of infection on workup. So our diagnosis, the thing that's most likely is this exacerbation of his heart failure. So heart failure, the way heart failure works, without overwhelming you, I'm a GI oncology PA at heart, so I have to do a lot of the knee bone is connected to the hip bone sort of thing whenever I'm thinking about heart stuff. So there's a lot of different categorizations of heart failure. You'll hear it described when you're in PA school as different things. Essentially, it can be a pumping problem or a filling problem. And so your heart is failing one way or another because it's not getting enough blood out of it. It's not circulating the blood in your body well enough. That can be sometimes because the heart gets stiffened and it can't open and fill, or it can't contract properly. It can be because your heart got floppy for some reason. It's just not doing the job that it should, and so it's not able to push and contract the way it should. Okay, so this guy has an underlying condition. I hope we have a volunteer. This guy has an underlying condition, right? So we know he has heart failure and it suddenly got worse. And so it gets worse by one of these three ways. So it's either his behavior, something he did, or a direct cause, meaning it's coming from the heart, something happened with the heart that's making this worse all of a sudden when we know he's had this condition for a while, or it's indirect. It's something going on in his body that's not the heart, not coming from the heart, but affecting the heart. Okay. So is there a volunteer? Did I scare you off with my pumping and
yes, let me see. Does anyone want to come on to answer the case study or go through the case study with Ryan? Make sure you raise your hand. So you can continue, and I'll see if anyone raises their hand.
Okay. This is the easiest question. So if you're not if you're not on board with this question, you're going to miss out on the so if anyone even wants to answer in the chat, any ideas on behavior, on what a patient might do that could worsen his heart failure? What's something a patient could do, just in the realm of possibility? What could a patient possibly do that influences some chronic condition?
Yeah. What can a patient do to make a chronic condition worse, to exacerbate it? His heart failure. What could this patient have done?
I don't know which way this chat goes, so you're going to have to tell me how they're coming in. Oh,
okay. Some people are answering. I see smoking. A lot of people smoking, diet, high sodium.
Okay. Great. So some of these are what can make you. So, okay. So let's cut through. Whoa. Great answers, guys. You're on to this, guys. MO. So not eating well, smoking, not exercising, that can make you prone to cardiac disease, right? It can make you prone to heart disease. Acutely, it is probably eating and drinking, right? You don't suddenly start smoking, or this 82-year-old guy isn't going to take up smoking all of a sudden and then throw himself into this condition. Smoking won't do it that fast. It can cause chronic heart disease, but it's not going to cause kind of this acute issue. So for his behavior, hold on, I'm pressing the wrong button. It can be medication mistakes, right? So he's not taking his medications properly, right? We know he has heart failure, he's probably on medications for it. He's not taking his medications properly, or dietary changes. Too much salt, great answers. Too much salt, lack of adherence to his prescription, awesome. And there are some other things that you can do. These are the big ones. So patients with heart failure often have to watch how much they drink, because you're not able to pump your fluid properly, right? So if you put too much into your body, there's going to be a backup. It can be just that he forgot his medication or messed up his medication, or that he ate something really salty. See a lot of heart failure after Thanksgiving. So Thanksgiving's pretty quiet in the ER, and then the next couple of days is full of heart failure. Any ideas? CHF secondary to COPD? Yes. So Kelly asked, CHF can be secondary to COPD. Yes. So you can have right-sided or left-sided heart failure. So there's all different kinds of sub-classifications of heart failure. So the right side of the heart, you receive in the right side of the heart receives blood from the body, delivers it to the lungs. Right, so the oxygen's been stripped out by the body, and then the heart's pumping it back to the lungs. The left side receives oxygenated blood from the lungs and then pumps it out to the body. And so if there's a backup in the lungs, then that will eventually cause issues in the heart. So that's the heart failure is often a consequence of something else going on in the body as well, can happen directly from the heart. Direct cause. So something that comes from the heart itself. So something that the heart causes. Any ideas about a direct cause of what would be suddenly worsening this heart failure? Okay, so congenital heart defects can. Are we thinking that suddenly got worse in an 82-year-old? Okay, Juliana, you got it. MI. So heart attack is the most common. So a direct worsening, weakening, inability to pump of the heart. And so other things can affect it. Certainly we can have heart failure that comes from blood clots, kind of something that happens downstream, sudden worsening of high blood pressure. But when it comes to the heart itself, something that is suddenly worse of the heart in an 82-year-old man, probably a heart attack. Indirect causes are things happening in the rest of the body that can then affect your heart suddenly. So a lot of these have already come through with good ideas. So I've seen renal failure come through. Blood clot, kind of something happening elsewhere, can certainly cause it. AFib, SUHA, good one. So if you are suddenly in atrial fibrillation, that can be a direct cause of heart failure too. And so that might be something you need to correct in a patient, is correct their irregular heartbeat. and then see if their heart failure corrects itself, or does it have a pumping problem that's kind of causing that. High blood pressure, renal failure, kidney defect. Yeah. So kind of things that are downstream. Kind of like awesome one, pneumonia. So infection can cause it. People who are on steroids for in this case, perhaps a COPD exacerbation. People who have uncontrolled sleep apnea. So things that are that affect the heart, but are not kind of acutely going on in the heart. So definitely something that we see as causes of heart failure. Sometimes new medications can cause it, or a medication change. Not the patient's behavior, it's something we did, right? So anything that can cause kind of an arrhythmia or a heart condition would be direct. Indirect would be things that are kind of outside of the heart. So in this gentleman's case, we treat them exactly the same, whether we're almost exactly the same, regardless of what the source is. Acutely, if someone's having shortness of breath, if they have low oxygen levels in their body, if they need supplemental oxygen, we're not going to treat them any differently to treat the acute issue. So we're going to treat them exactly the same, regardless if he just messed up his medication, or we're also going to treat the heart attack if someone's having an acute heart attack. But usually if this is their presenting symptom, the heart attack has already passed and this is the consequence of it. And so we're going to treat them exactly the same, but long-term, we want to be thinking about what the underlying cause is to know, is this just a temporary treatment and we're going to go back on the treatment he was on before? Or is this something that we're going to see that we need to change long-term medications? Okay. So the beauty of, what we start him on is oxygen and IV Lasix. And so we're basically squeezing his kidneys physiologically and making his kidneys work to filter out that fluid, and he's going to pee a lot to get rid of the fluid overload. So once we have him home, so we kind of start our treatment, roll in our oxygen tank, set him up with an IV. Once we have him home, we have a lot of advantages in being home with patients, because I treated patients for so long, and I always thought I was giving such clear directions and good discharge instructions for patients, and really kind of making sure that everything was clear, having patients repeat something back to me. And what we see now when we go into the home is even patients who seem totally with it make mistakes, or they have a setup that's wrong, or they have a fantastic caregiver who you think is with it, but there's something that they misinterpreted from before. So what we find when we go into this patient's home is he had an accidental medication noncompliance. He had been in and out of the hospital for a couple of hospitalizations spread out, probably twice over 3 months before this came up. And what we see with this is that some of the discharge instruction didn't quite translate to when he got home. And he's got lots of pill bottles at home, and he's got med cassettes where his wife is putting in the different medications. And there was just some mistake. He misinterpreted how much he was supposed to be on, so he's taking too low of a dose. The other thing that we found is he told us in the hospital he had been compliant with his CPAP machine. When we get into the house and we ask to see it, he says the mask is too small and it kind of squeezes his face, and he never actually wears it. And so in the hospital, he can kind of lie to us. At home, when we kind of see it packaged up in the box, they confess up. The other advantage to being in the home is that our nurses can be doing a walkthrough. So our nurses are, their background is in a lot of them work in home care, in cardiac ICU, in a medical ICU. And so our nurses are they're wonderful. They're very direct with patients too. And they'll say, show me what you're eating. Let me see what's in your cabinets. And so our nurses have the advantage that they can go through, usually on the second visit when we're not there, go through a patient's kitchen and say, this is how much sodium is in the food that you're eating. This is what to check on the label. This is kind of what to watch for and how to track that during the day. And we have the opportunity to really do a lot of education for patients that we just we just don't have the opportunity. We don't have the information in the hospital that we have at home, and kind of seeing patients in their own environment. And so this is a huge advantage. And so in our case, we got the gentleman set up with a sleep study and kind of got his CPAP on point. We set up, we're very clear with the directions at discharge. He was able to go back on the exact same dose that he should have been on, and was maintained out of the hospital for at least 6 months, the last I checked. And so that's all it really took. What we did to kind of reinforce this plan, because sometimes it is, this patient and his wife, his caregiver, had excellent capacity. Sometimes it is a patient that's home and independent, but we're kind of worried about whether or not they're really taking their medications as they should, that sort of stuff. And there's a lot of services that we can bring into the home. This case, we treated this patient to his dry weight, what should have been his weight, weaned him off the oxygen until he no longer needed it, discharged him on an oral regimen, and we set him up for VNA to help manage the medications and just check in on them with a visiting nurse and make sure that the wife felt comfortable each kind of week to week filling the pill boxes for a few weeks. And then she also was able to check in with the patient, make sure he was monitoring his weight and tracking for any trends, and notifying his cardiologist if his weight went up by 3 pounds in a day, 5 pounds in a week, whatever the parameters are that we set for him. And then we got to discharge him from our service on day 5. And so we get to do we get to do all the care he would have gotten in the hospital, but also kind of do a soft landing for him, because we know exactly what's going on at home for the patient, so that he's getting all the support he needs to prevent rehospitalization. Okay. Any questions coming through that I should be fielding readily?
Yeah, that was great. I think especially the weight monitoring. I actually remember that being my professor telling me that in PA school. And I think that was even a test question, like what's the easiest way for patients to monitor for possible exacerbation of their CHF? And they just get on a scale and like check out their weight. So I think, the weight monitoring is a big one. and I'm sure it'll be a test question.
Whatever their weight is. So if it's right-sided heart failure, if it's left-sided heart failure, if it's preserved ejection fraction, restricted ejection fraction, kind of all these subsets of heart failure, they should gain weight, right? Where they are storing the extra fluid may change depending on what kind of heart failure they have. They might have swelling in the legs, or it might pull in the belly and they have abdominal distension, or it's in the lungs and they're having trouble breathing. But regardless of where it is, it's weight, and it's going to show up on the scale. And so the other thing that's really interesting, I've learned so much about kind of what's available in the home from our nurses that have a lot of experience working with patients in the home, is there's a lot of resources to help patients, especially elderly patients. There might be elder services that can help them kind of avoid hospitalizations, or have some services that come in. A lot of the Meals on Wheels may have a low sodium option. So patients that are getting even meals brought into the home, a case manager or a nurse can reach out and make sure they're getting the low sodium option. We have what's called telemonitoring for patients. And so it is basically a scale that communicate directly to their cardiologist office. And so the nurse in a cardiologist office gets flagged for anyone's weight that changes so much in a day, or blood pressure that's too high. The VA were pioneers in this kind of telemonitoring, not telemedicine, but telemonitoring. And really having kind of their patients check in with blood pressures, heart rates, so things that you can catch something early, and then a nurse from the practice can reach out to patients. And usually there are qualifications for that. You have to have a cardiologist or PCP, and you have to sometimes be homebound. But there are lots of different services that you can get for patients, especially elderly patients, in places that you might not know. So home care nurses are awesome resources. If you just ever come across one and have questions, they know about all sorts of things that patients can get into the home to prevent hospitalization, prevent worsening of chronic conditions. Okay.
Yeah. So is that an app, the monitoring, the telemonitoring? Is that like via an app?
No, they have like this program with Mass General where some technician comes and sets up a scale and like a automatic blood pressure cuff in their home. And then some magic happens and their doctor's office gets the readings every day, or gets readings when they can set parameters and they get notified when the patient's outside of parameters. It helps the patient kind of be reminded that they're supposed to do that every day. Some of them will like make noises or talk to them and tell them it's time to weigh themselves. So it can be good, especially for folks that don't have extra support at home, to bring in some of these tools. So they're not, the one having to call their doctor's office and say, hey, I'm 2 pounds up. They don't have to kind of fight the phone triage, and it can just automatically happen.
Oh, that's really cool. So, someone said, do you treat ascites? Before we move on to the second question, so I see someone asked, do you treat ascites?
So usually not. We will treat ascites whenever it's heart failure related. Oftentimes, if it's ascites to the point that they would be hospitalized for it, like if it's liver failure, they usually need a TAP, and so they can get a paracentesis and go home. But I treated a lot of ascites in GI cancers, and so we would tap people, and maybe they're on Lasix and spironolactone, kind of a loop diuretic, and Lasix, and those patients do pretty well on orals. And so usually you're not just constantly diuresing someone. Usually you have to, the volume requires that you tap them, or you can treat them with oral if they're pretty responsive. You're not fighting so much a lack of, or like a cardiorenal pathway. You're not fighting it so much. It's really just kind of a recycling pathway in the belly if it's ascites because of liver failure or because of GI cancer, ovarian cancer are the common causes of ascites.
Okay, thank you. That case study was great. You were getting a lot of great feedback. So I think we have time to do one last case study and then answer any remaining questions. Thank you so much, Ryanne.
For sure. This one will be simpler, just in case we couldn't make it through. I put these slides in the middle. Okay, case number 2. Younger and simpler. So 35-year-old woman with a history of cervical cancer. She's had a hysterectomy. She's had chemo and radiation a few years back. She has a history of UTI, and she had an implant. And so as part of the surgery, had her ureter re-implanted on her bladder. And so a couple of risk factors going in to set her up for UTI, and she's got a history of UTI. So she came into the emergency room with left flank pain, painful urination, and pain right above her pubic bone. She is the primary caregiver of 2 young children. And in our mind, the little perk was that she was a nursing student. So this matters with some of our decision-making, because sometimes patients are treatable at home. We can do more at home if they can do more of themselves, if we can teach them. So in her case, in this case, this is a patient who should absolutely be getting IV antibiotics out of the gate, because she has so many different risk factors for a UTI or for complicated UTI. And so let me see if I give it away in the next slide. Real quick, I won't take a lot of time. What are in her history here? What are some risk factors that you see that make her a setup, or potentially setup, do you think might make her a setup for a more complex UTI than someone that would just go into their PCP's office and could easily get Cipro or Bactrim?
So what are some risk factors specifically for her? What's in her past medical history, guys?
Yeah, so radiation, the implant. So radiation, the implant, and her history of UTI. So chemo shouldn't do it. Not if you're not an active chemo, it's not suppressing your system. The current symptoms shouldn't do it. If we're suspicious that she's got pyelonephritis, even without her history, we're probably going to treat her with IV antibiotics from the get-go anyway. But it's really anything that is disrupting the natural anatomy, anything that can cause a kink, anything that causes scar tissue that can mean that bacteria is fluxing back up to the kidney. And so all the things that cause those setups. So not so much cancer, but the fact that she had radiation and surgery cancer can make her a setup. So Oh, someone said childbirth too. Good one. That wasn't intended as part of it, but yeah, that certainly can be, especially kind of right after or before. So on her workup, we saw an ultrasound with slightly decreased left hydronephrosis from her previous ultrasound. So she had hydronephrosis before because she's got a history of UTI. She's also got a history of that left-sided implant. And so she lived with a little bit of fluid and dilation around her kidney, which is what hydronephrosis is. She had a culture with her primary care doctor that she got a culture right before she came to the ED the day before. And so we had bacteria in the culture. We knew that we had a kind of raging enough infection to treat, but we didn't quite have an antibiotic sensitivity yet. So this is kind of what we talked about, these different structural anomalies that can make you prone to bladder infection. The other thing is, other than structural, is do you have some sort of nerve damage or neurologic disease that is going to change your signaling? So you're not going to feel when you need to empty your bladder. Or do you have something that makes you immune compromised? And so it could be diabetes, it could be compromised immunity, it could certainly be a patient who's undergoing active chemoradiation who might have suppressed white count, who might be prone to infection, not typically after the fact. Okay, so we take her home from the ED, and what do you want to know before you prescribe anything for her? What would you want to know kind of off the bat before I choose what antibiotic to give? What do I want to know about her potential history before I choose a drug? Allergies, what bacteria is present, right? So we have bacteria, we don't have sensitivities. So this is as good as it's going to get. Current medications, great. What other medications is she on? Prior allergies, yeah, drug interactions. So perfect, that's what we want to know. We only have so much information to go off right now. Now, let's say I prescribe antibiotics for her and it's 2 days later. What do I want to know a couple of days later, or what would you want to know a couple of days later after you've already given her, after you've already chosen an antibiotic and you've been giving it to her? Yeah, Tony, antibiotics will be broad spectrum to start. Yes, Kieran, any improvements? Right. Does she have any symptoms? Can we change her to Cipro? Right. Side effects? Yep. The other thing we should have in a couple of days are the final sensitivity results. And so we can refine our antibiotic choice or switch her to oral if within this time frame, right? So we're hoping, we're kind of assessing her symptoms, making sure her symptoms are getting better. But really, we're not going to know what the right drug regimen is, especially in this patient. We want to cover her until we have that answer. Not just until she has symptom improvement because of her complex history. So we gave her IV cefepime every 8 hours, which is not typical in the home, but she's a nursing student, so we can teach her how to change out her line and hang her own bag once a day. And so she's willing to learn that. We'll do the first few doses. We'll do 2 doses a day. She does the third. And so we're monitoring for final culture results, and then transitioned her to oral antibiotics whenever it was appropriate based on cultures and based on her resolution of symptoms. All right, guys, that's all I got. There was a question from Aviva that I wanted to ask, and now all of your great answers rolled in, and I missed it, but it was the question about oncology and specifically.
Whether nurse practitioners usually practice in oncology, because there were a lot of nurse practitioners in her area.
Yeah, so I think it's so much practice driven, like history of practice driven. So when I worked at MD Anderson, there were departments that were more heavily nurse practitioner than PA. My department was all PAs. There were 20 some of us in GI medical oncology. Surgery, there's more of a hospital bent toward PAs and more of an outpatient bent towards nurse practitioners. So that's actually what I found when I was looking for jobs in the Northeast, where a lot of outpatient positions were posted for NP. Not that they wouldn't have taken PAs, but I might have been the only PA in the department, whereas inpatient oncology or other inpatient roles were heavily PA. And so it just depends. And sometimes it's, there's some different licensing requirements. And so if they have an administrator who already has all the paperwork that they know they need for a PA or a NP, it just might be easier to hire one versus the other. In my position, it was actually listed as an NP whenever my job was posted. And the other PA who I work with strong-armed them into changing it to NP or PA and said, hey, we can do this too, like, let us in. So luckily she did that about a month before I applied, and then I got into the practice as well. So that's how we got to be the first 2 PAs in home hospital. I wanted to share this one thing too, in case you're prepping for PA school and you have a little time. Here's a resource that you can download. If you go to that tag at the end, you can go to my website, be a physician assistant /6 pillars, kind of get a checklist of all the different elements, the 6 important elements to prep for PA school if you would like that. Did I miss any questions that I should be covering, Rodaline, as we finish up here? Sure.
I don't think so. I don't see any other questions. A lot of them, were general about the PA career, not anything specific to hospital medicine. But it seems like you answered everything, and you did a great job. They seem to really, really like it and like the PowerPoint. Thank you so much.
Sure.
And thank you for providing the 6 pillars and how they can get on the website and see that.
Sure.
Thank you so much.
It helps to have somewhere to start. I know what it's like to have absolutely nowhere to start. And the PA that I shadowed in pediatric neurosurgery, poor Julie had to answer a lot of questions for me because websites did not exist on this when I went to PA school. There weren't social medias to watch what PAs were doing. And so Julie was my lifeline. I hope I can be the Julie for other people out there who are looking to figure out what to do for PA school.